So good morning, good afternoon, good evening, everyone, depending where you are. Welcome and thank you for joining us. My name is Olga Popova. I'm a senior researcher in economics and at the Leibniz Institute for East and Southeast European Studies, and also the Global Labor Organization cluster lead in religion. And I'm also editing this section on religion in the Handbook of Labor, Human Resources and Population Economics, for which Professor Klaus Zimmermann is a chief editor. And today's talk on religion and mental health will soon appear as a chapter. Please follow this project for many interesting chapters. Some of the chapters have already been published, including my own on religion and happiness with Vladimir Otrashenko. And it is my very great pleasure to welcome you to this plenary session. Today's talk is actually a joint one with the regular Global Labor Organization monthly research seminars, which are normally led by the GLO director Matlub Piracha. And it's more than great pleasure to introduce you our today's speaker, Professor Sriya Iyer. She is a professor of economics at the University of Cambridge. And she also serves as on the board of directors of the Association for the Study of Religion, Economics, and Culture. In her career, Professor Iyer had very many prestigious awards and fellowships, and her research on development economics, religion, demography, education has appeared in the top economics journals, including Journal of Economic Literature, Journal of Political Economy, Journal of Development Economics, among many others. Without further ado, I would like to give a floor to Professor Iyer. Just to the audience, the questions could be asked in the chat, and at the end of the talk, we will have some time for the discussion. So Professor Iyer, please.
Thank you very much, Olga, for the very kind introduction, and to you, to Mehmet, to Klaus, and others for the very kind invitation to be able to speak in this GLO session, as well as the EBIS conference. I'm just going to share my screen with you so that you can see my slides. May I confirm that you can actually see them now? Thank you. So I'm absolutely delighted to be here, and thank you all for joining this particular session of the conference. The subject of my talk today is religion and mental health, and this is actually a field that I've been interested in for some years now. It's relevant to a relatively new field of economics research that we call the economics of religion, and there are many here who have made wonderful contributions to it, like Olga and Ira and others. But in general, compared to other fields of economics, it is a relatively new field of economics research. And the reason that economists are interested in this field is that 8 in 10 people today identify with a religious group worldwide. Pew Research shows that 36% of Americans attend a religious service weekly. And in general, it is believed that religiosity is correlated with per capita income. So in this particular figure, for example, this is data from the Pew Research Center's Religious Landscape Study in 2019. And what this is essentially showing you is per capita income on the x-axis. It's showing you the percentage of people who say that religion is very important to them on the y-axis. And in general, you're seeing this broad correlation. Poor nations in general tend to be very religious. The wealthy are less so. And the one great exception to this rule is, of course, this country in the right-hand corner here, the United States, which I'm going to be talking a little bit more about in this particular lecture. But in general, we know that the US is a country that is one of the richest countries in the world, as well as the most religious. And it's really to this literature that I feel this area of religion and mental health has something to say. So as Olga mentioned, this talk, as well as others, are based on the Handbook of Labor, Human Resources and Population Economics, edited by Professor Zimmermann, and Olga is the section editor for religion. I'm very grateful to them for the opportunity to to have been able to write this handbook paper with my colleague Giovanni Rosso. I should say Giovanni is a young master's student here at Cambridge and is now working in Rome, but hopes to do a PhD in the future. So this was also a wonderful exercise for a young economist to be able to be involved in academic research. Now, the paper that we wrote, the handbook chapter, is describing the relationship between religion and mental health. And we're arguing that it has immediate as well as long-term policy relevance, as well as empirical challenges, and that therefore this is a very new, exciting frontier of economics research. What we're saying mainly in the handbook chapter is that there are numerous cross-sectional studies that document a positive effect of religiosity on mental health, stress coping, and life satisfaction, but that causal investigations are basically fewer. They're largely focused on North America rather than on developing countries. So today I'm going to outline a little bit of that literature that is talking about religion and mental health, and then hopefully also get a chance to talk to you about a project that is currently work in progress, which we are doing on religion, mental health, and COVID-19 in the United States. So a lot of World Values Survey data between 2017 and 2020, which we analyzed for the handbook chapter, suggests that there is a difference of 5 percentage points between those who belong, that is those who attend a place of worship and report higher levels of life satisfaction compared to those who do not attend, and that this is also true of those who believe, those who pray daily and report higher life satisfaction compared to those who are never praying. And the difference is roughly about 10 percentage points. In our handbook chapter, and I'm not showing you the results today, but just summarizing them for you, we use 65,564 observations from the World Values Survey with regressions of life satisfaction on religion, with controls for gender, age, marital status, education. And in general, what we're showing is a correlation that religious membership is positively associated with life satisfaction by 10% and is highly significant even after controlling for other factors, such as the frequency of prayer, service attendance, religiosity, and a belief in God. Now, in the paper, we do talk first about the broad channels through which religion might possibly affect mental health. And we argue that there may be 3 broad ways in which you can think about this link. First, that religious communities might be very effective in creating social capital. If we think of social capital as the norms and networks that are based on reciprocity, then a shared religious background might well foster those kinds of networks. At the same time, there is a little bit of literature to suggest that religiosity might act as a coping or a meaning-making device. And I'll talk more about this a bit later on, about religion acting as a stress buffer. And then, of course, we know that all religions may prescribe or indeed proscribe certain practices. So you could find that if you're religious, this might reduce your chances of undertaking deviant behaviors. At the same time, it could be that if a religion proscribes certain practices and you adhere to those practices, it might then affect your mental health if you feel that you are not adhering to the practices of the religion. So in general, we think there are lots of broad channels through which the link between religion and mental health might be something for economists to consider. Now, in the handbook chapter, we looked at the broad social science literature on this subject. And most of the studies that are available tend to use cross-sectional data sets, and they discuss correlations between religion and mental health. There are a number of reviews of this particular subject, not in economics, but in other subjects. But in particular, in the last few years, there's been a mushrooming of interest in this topic more broadly in sociology, psychology, and related disciplines. So I particularly want to highlight the comprehensive reviews of this subject by Koenig, Rosmarin and Koenig, Garson, and others. Now, what does a correlation mean in this context? A correlation, which all of these comprehensive reviews document, it means that either religiosity affects mental health positively or negatively, or that an individual's mental health influences the probability of the individual being religious. And so what we're arguing in our paper is that we probably need, in addition to these correlational studies, meta-analyses, longitudinal studies, and possibly a range of different econometric techniques to identify a causal effect of religiosity on mental health. Now, just to give you an example of the kinds of contexts which economists have been looking at and others to think about this relationship, one area of, I think, very profitable research has been this area of war traumas and religiosity. And there's some lovely papers by Cesar, Sabia, Friedman, Sharma, Koenig, and others, where they've been looking essentially at war veterans who were exposed to traumatic events and have a high risk of mental health disorders. Particularly what they've been documenting is that after 9/11, this includes post-traumatic stress disorder, traumatic brain injuries that are being caused by the explosion of shells and mines. And there are some studies that are suggesting, again, it's correlational evidence that religion reduces the risk of current and lifetime PTSD, as well as alcohol use disorders and suicidal ideation. One of the few papers that has actually demonstrated a very nice causal link between religion and mental health is this paper by Cesar, Friedman, and Sabia that we discussed in a lot of detail in the handbook chapter. They exploit the random assignment of soldiers to combat zones that are being based on military characteristics, which are exogenous to religiosity, and thereby they suggest that perhaps this relationship between religion and mental health is more than correlational and that it is causal. The other area where you see quite a lot of research is looking at substance use by adolescents and religiosity. And this, again, there's a correlational association which is significant for both males and females because suicide is considered by the CDC as one of the leading cause of death amongst youths in the US between the ages of 12 and 17. There is research that is looking at religiosity and suicide ideation. At the Harvard School of Public Health, Professor Tyler Vanderweel and co-authors conducted a longitudinal study of 89,000 women nurses, nursing considered to be a very stressful occupation, and showed that attendance at a religious service once a week compared to never attending was actually associated with a 5-fold decrease in the risk of their suicide. This is also substantiated by other studies by Chen et al., all very recent studies. Again, it's a longitudinal study of the US that's showing that those who attended a religious service have lower risk of mortality, smoking, and heavy drinking, and that also religious service attendance is negatively associated with depression and anxiety. I'll talk more about that particular link in a minute when I discuss some of the research that we've been doing in this area, but just to sort of highlight the kind of work that's being done on the US at the moment. Now, you might legitimately think, well, that's the research on the US. What about more globally? So in the handbook chapter, one of the things that Giovanni and I did was to look at the World Value Survey data and simply regress life satisfaction on religious membership and extract beta, which is essentially the relationship between religious membership and life satisfaction for a range of countries after controlling for demographic factors. And actually, when you're looking at this particular picture, the area, these are all different values of beta for different countries. Blue basically indicates a positive relationship. Red indicates a negative relationship. The darker the blue, the stronger the relationship. And in general, if you're looking at the global picture actually suggests that there is a lot of diversity. The strong relationship that you might be getting in the United States, you're not necessarily getting it for all the countries in the world. So one of the main themes that we're pushing in the handbook chapter is to say we need a lot more research on mental health and religiosity in the developing world. We don't have a lot of data. For example, big countries like India here, the country that I belong to, didn't actually ask the questions that were relevant for us to be able to look at this relationship carefully. So thus far in the handbook chapter, and we would absolutely welcome people's comments on this if you get a chance to read the chapter later, that there is a lot of cross-sectional evidence on the positive and negative effects of religiosity on mental health. We're arguing that there is a need for longitudinal studies that cover a range of definitions as well as well-being indicators. In general, the cross-sectional evidence is suggesting that there is a positive relationship between religiosity and psychological well-being in the cross-section, and there are a few longitudinal studies that are also showing support for this, but that all of this research is largely drawn from the United States, where there are good data sets, I think, that are looking at some of these questions. What we do conclude in the handbook chapter is that the global literature on religion and mental health, we say, is actually not in fact global at all. And so what we really would urge is, if there are bright graduate students out there, please think about this, looking at religion and mental health in a broader context. Of course, research on the United States, but also research more broadly on developing countries. Now, the handbook chapter is essentially reviewing the literature in this particular field, and it's related to a project that I'm doing at the moment with several other co-authors in the context of something that all of us have lived through for the last 18 months or so, and that's the pandemic. So one of the things that we've become interested in is looking at religion and mental health in the situation of a pandemic. We know, of course, that COVID-19 is a pandemic that's absolutely an international battle. Many economists right around the world have already documented and shown that it has affected employment, economic growth, and well-being to very significant degrees. We are, of course, interested in the key factors that led initially, at least, to the rapid diffusion of COVID-19. And one of the factors which you might not have thought very much about is the role of religion. And this is something that I felt should be investigated more, largely because very early on when the COVID-19 pandemic started, there were many articles and others that said that 9 out of the 54 COVID-19 super spreader events across 28 countries were in fact religious gatherings. Now, being from India, how can I not show you a picture from India to talk about the spread of COVID? This is an example of the very famous Kumbh Mela. It is a very large Hindu festival that takes place every 12 years, and it takes place in Haridwar in India. This happened in April 2021. As you can see from this picture, as the BBC report on this pointed out, there was very little mask wearing, very little social distancing, and this was really at the height of the pandemic in India. And it was established soon after that over 2,000 devotees, or probably more devotees and religious leaders, did actually contract COVID at this particular festival in Haridwar. So it made me feel that this is actually an issue that we should be investigating more. So our research project has 2 bits to it. One bit, which I'm actually not going to talk about too much today, but which is a big part of the project, is how do religious gatherings and religious networks themselves spread infectious diseases such as COVID-19, as evidenced from the case of the Kumbh Mela and other instances. And then the second bit of the project, which I'm going to focus a bit more on as it's relevant to this particular topic, is how have the COVID-19 induced restrictions on religious congregations actually affected mental health at all? The research team that is involved in this project is reasonably large. It consists of assistant professors, PhD students, postdocs, young economics undergraduates at Cambridge, all of whom are interested in this topic. So I do want to highlight that this research team involves Girish Bahel, Anand Srivastava, Kishan Shastri, Kutu Shastri, Giovanni Rosso, Clementine Rose, Robert McLennan, and myself. Now, the first question that we wanted to think about is why should actually religion affect the spread of disease? Because there was a lot of media speculation early on in CNN, by Reuters, The Guardian, and other places, suggesting that religion might have affected the spread of COVID-19. In terms of the academic research on this subject, though, there is a nice paper by Janet Benson, which she published in the journal COVID Economics, where she pointed out that in times of crisis, people pray, and that the Google searches for religion and prayer and so forth had become very strident just around the time when the pandemic broke. But there's also, of course, an economic history literature that Mark Koyama and Noel Johnson and others have been writing a lot about, which has also suggested that in terms of crisis, in terms of climate shocks or natural disasters or other kinds of disasters of various kinds, people might persecute. And of course, they have this wonderful book called Persecution and Toleration that talks about the persecution of Jews in medieval Europe in response to various climate shocks. I've been doing some work with Rohit Tikku and Anand Srivastava looking at a very different context. We've been looking at temple desecrations in medieval India. And again, again, we've been showing that climate shocks have been quite important for religious persecution there in ancient periods. So I think this idea that in times of crisis, people might pray, in times of crisis, people might persecute, might be generalizable across most of the world's religions. Again, it's something I think to investigate, but something that I think as economists we should be interested in. So in this particular study, what we're first looking at is whether an increase in religiosity in response to pandemic news might actually affect the network that determines the spread of the disease. Because on the one hand, a religious network might well become denser because those who are already religious might actually spend more time with their co-religionists. That theoretically might increase the chances of infection. On the other hand, you might find that people are substituting away from other activities such as sports or recreation, and that could decrease the chance of infection and indeed the infection spreading from people within a religious community to people outside it. So what we're trying to do is to test this hypothesis first globally by collecting data to examine large and small congregations and how this might actually correlate with the instance of COVID-19. So what we're really doing at the moment, and I have to say this project is very much, work in progress. We're comparing differences in the effects of the small frequent gatherings, which are often mandated by religions such as Islam and Christianity, with the large infrequent gatherings, such as the Kumbh Mela, which is mandated often by Hinduism, in order to suggest how infection might possibly spread. And just to give you an example of how we're doing this. So in the survey that we conducted in the US, which I'll talk about in a little bit, we had questions of this kind that we asked about congregation size. So for example, we asked, these were respondents in the US, before COVID-19, think of December 2019, what was the size of your religious congregations? And then we've asked during February to March 2020, before the COVID-19 restrictions were imposed, did you feel that there was a change in the size of your religious congregations? So we're actually using different methods to try and get at these congregation sizes across different parts of the world, and that's one part of the project that we're considering at the moment. The second part of the project is actually looking more at the interaction of religion and COVID-19 induced restrictions and how they might have actually affected mental health. And this is, of course, more relevant to the handbook chapter and the kinds of issues that I've been discussing thus far. Because while it might be the case that religious gatherings fuel the rate at which an infection might possibly spread, you could find that consequent lockdowns or various social distancing measures of various kinds might themselves have some effect on religiosity and might themselves have some effect on health. Now, we know from our own individual personal experiences, whichever part of the world we were in, that the public health measures that were announced by different governments restricted all gatherings. And this might have significantly affected followers of religions that actually mandate regular communal gatherings at places of worship. And what we're arguing here is that this might have important consequences for the way in which people actually practiced religion, not just because they were not being physically present at a place of worship, but also because, not being physically present at a place of worship, if that is something that you do regularly, cannot easily be substituted with electronic means of team communication. Now, we know that in all non-religious spheres, and even now this particular talk is virtual, we have been substituting various kinds of social interactions with technology and non-in-person interactions. But in the religious sphere, sometimes it may not be as easy to do that. Of course, this doesn't mean that people haven't tried to do that. So this picture here is basically the Royal Choral Society from England that sang in isolation the Hallelujah Chorus from Handel's Messiah on Good Friday on the 3rd of April 2020. This was an unbroken tradition that they would always do in the Royal Albert Hall for 144 years. So they were very keen to continue with the tradition. And of course, they tried doing it in lockdown as well. Now, one of the issues that I think one should consider in a bit more detail then in that context is does religion at the individual level then have a causal effect on mental health? And so I spoke earlier on about a lot of the correlational studies that are suggesting that religion has an effect on mental health, but is there any kind of causal effect on mental health that we can actually identify? So this is actually an issue that I've been interested in long before the pandemic. The pandemic has given us an opportunity to re-examine this relationship between religion and mental health. But I've actually been working on this for quite a long time before the pandemic. And in 2019, with dear colleagues Jane Fruworth at Chapel Hill and An Wen Zhang, who's now at Glasgow, we did actually publish a paper in the JPE in which we argued, I think quite forcefully at the time, that religiosity does affect depression and that relationship is causal. So we used, at the time, we used a nationally representative sample of 20,000 US adolescents. We used the AdHealth data who are in grade 7 to 12. We had information on their school and home environment. And essentially what we argued in the paper, I hope you will get a chance to read it. But in a nutshell, what we were arguing in this paper is that a 1 standard deviation increase in religiosity decreases the probability of being depressed by 11%. What does a 1 standard deviation here mean? It meant that if you attended church once a week, this decreased your probability of being depressed by about 11%. What we also did in that paper was to show that peer religiosity predicts own religiosity, and that link might be causal, and that more depressed individuals benefited significantly more from religiosity than the least depressed. In that paper, we suggested a framework for how religiosity can help you deal with depression. We argued that religion could provide psychological resources to improve self-esteem that might help people deal with depression, that it provides coping skills. So we looked at the difference between active problem solving and passive problem solving and ways to approach problems, and suggested that for adolescents, at least, that might be one way in which religion helps you cope with depression. We argued that religion actually provides a lot of social resources, whether it's helpful friendships or neighborhood resources or direct financial aid. So I published a book as well in 2018 on the economics of religion in India, where I argued that in the Indian context, definitely, there was a considerable amount of evidence to suggest that religious organizations are really intervening in providing education, healthcare, microcredit, employment, and various economic activities that you wouldn't actually have expected religious organizations to be involved in because of the lack of provision by the state. And so we argue in this paper also that these social resources might actually be an important way in which religion helps you deal with depression. And then we also argue that religion might reduce the exposure to stresses. So if you face a health shock, or if you faced a family or a friend's suicide, religiosity might help you deal with those kinds of shocks. We also showed that it might help foster more stable home environments. So single parent households, for example, in this study were affected more by religiosity than other households. Now, how did we actually show that the link was causal? Is there a question?
Yes,
Okay, so how did we actually show that the link was causal? So, there is, as many people here have worked on these issues and pointed out that, peer effects have been very important in many economic studies of drug and alcohol use, academic performance, and religiosity as well. And so in our paper, essentially what we were doing was to create a quasi-experiment. We were saying that by chance, students in some degrees, maybe grades, may be exposed to more religious peers. And so you can then isolate the effect of individual religiosity on depression using the variation in individual religiosity that comes from the random variation in the religiosity of the school grade peers. And so if certain adolescents became more religious because of exposure to those religious peers, you can then investigate whether those same adolescents also showed improved mental health. And that's what we essentially showed in the paper. Now, this is just to give you an idea of some of the results that we had there. Essentially, we argued that that for that US sample of adolescents, if you were female, you were more likely to be religious and more likely to be depressed. If you were Black rather than white, you were more likely to be religious and more likely to be depressed. If you were Catholic, you were more likely to be depressed. If you came from a low-income household, you were more likely to be religious and more likely to be depressed. And if your mother had a degree, a university degree and above, then you were more likely to be religious, but less likely to be depressed. Now, in the current COVID project, we're actually using very similar measures, both for religiosity and for depression. So in the current project, we're using self-reported symptoms of depression that are essentially used to diagnose depression in clinical settings. And it is based on the Center for Epidemiological Studies depression scale. This is basically based on 19 questions, which report how frequently people experience different symptoms of depression. And you can aggregate that response to create a scale that we call the CESD scale. Now, just to give you an idea of what are those questions that go into the scale, it's questions like this. You have to code the response from 0 to 3. So never, rarely, sometimes, a lot of the time, most or all of the time. You were bothered by things that usually don't bother you. You didn't feel like eating. Your appetite was poor. You felt depressed. You felt that you were too tired to do things. You felt hopeful about the future. You thought your life had been a failure. You felt fearful. You were happy. You talked less than usual. You felt lonely. You enjoyed life. You felt sad. You felt that people disliked you. It was hard to get started doing things. You felt that life was not worth living. So as you can see, it's a range of questions that progressively sort of indicate more depressive symptoms. And what we do is simply to aggregate those responses to create the CESD scale. Similarly, just like with depression, we also created a scale for religiosity, which looked at things like the frequency of church attendance, church-related activities, prayer, the importance of religion. And some of those questions include things like, in the past 12 months, how often do you attend religious services? How important is religion to you? How often do you pray? But one of the things that we were interested in with the COVID project in particular was also to look at things like virtual services, the online discussion groups, drive-through confession, online choirs, other kinds of religious substitutes that were perhaps important during lockdown as well. Now, in case any of you were wondering how we actually classify all the various religions, this is a very conventional classification that is used for denomination in the US. It's used in many social science studies of the US. So if you are Presbyterian or Unitarian, you're classified as liberal Protestant. If you're Lutheran or National Baptist, you're classified as moderate Protestant. If you belong to Jehovah's Witnesses or you're Pentecostal or Mormon, you're classified as conservative Protestant. If you are Baha'i or Buddhist, Hindu, Muslim or Jewish, then you are classified as other religion. And if you're Catholic, you're basically classified as Catholic. So in our work, essentially in the survey that we did most recently for the Religion, COVID and Mental Health Project, from February to March 2021 this year, we basically conducted online surveys amongst 5,178 individuals. We had done 2 pilots in October and November 2020. And essentially what we're trying to get at is to elicit responses on how the COVID-19 restrictions in the past year affected 2 things. One, how did they affect religious practice? So we're looking at family prayers, virtual services, discussion groups, drive-through confessions, and how disruptions in practicing religion have actually affected mental health as well. So this is just to give you an idea of the respondents in our particular US survey. So each one of these little red dots that you actually see here are essentially one of our respondents. Now, for me, this was actually quite a new experience because normally in the field work that I'd always conduct to do research in India and other developing countries, it was always in person. It was always with a survey research agency. So to actually use an online survey, we worked with Qualtrics to do this. This was actually quite a new experience for me, but we were able to get the location because it's online of each of the respondents in the survey. Now, just to give you an idea of how they're distributed across the United States, this is actually a picture that's just showing you how many of the respondents were in the States, and they're obviously stratified demographically. So for example, we have more respondents in our survey from California here, than Texas, than from North Dakota, South Dakota, and Vermont. So essentially, we're sort of hopeful that the online survey is broadly representative of different states in the US. I thought I might share with you a qualitative comment from one of our respondents who said that he or she was I miss going to church, and the church-related activities used to be a big part of my life. Besides worshiping God, let's not forget that going to church is a social activity, and of course that's going to be felt under lockdown. People are lonelier now, and not attending church is a big part of that. Sad. So at the end of the survey, we just had a little area where we could say any other comments, and this was one of the comments that we received. So the key variables that we're interested in is mental health as measured by our CESD questions that I've described. We are interested in religiosity. We're interested in past religiosity and present religiosity. Again, I have to emphasize this is very much a work in progress study. We're interested in the strictness of lockdown, and the measure that we initially started using, which is this one, is measured as the number of days when the time spent outside the home was less than a threshold value. At the moment, we're also exploring other measures of strictness of lockdown based on announcements made by the various US counties, but this is the measure that I'm going to focus on today. And in order to get a time outside the home, we got this from the Google COVID-19 Community Mobility Tracker, Harvard Opportunity Insights Economic Tracker data, which has been created by Raj Chetty's lab. So we have socioeconomic characteristics of our respondents in terms of their age, their gender, their education, their race, their religion, their marital status, their household size, their income, their occupation, their industry. There's a lot of data here. We are very much still in the process of analyzing it and sort of going through this. But just to give you a sort of brief snapshot of what are the characteristics of our 5,178 respondents. Their mean age is about 44 years. They are 48% male. They are 78% white. They are 85% religious. Now, of course, if we were doing this survey in Germany, or we were doing this survey in England or somewhere else, we may not have so many who say that they are religious, but because this is in the United States, this seems consistent with other studies of the United States that suggest that it is a very religious country. 66% of the sample are Christian, 51% are employed, and 53% are single. So our initial, looking at the data once we finish the survey is suggesting that these are the socioeconomic characteristics of the group. In terms of the incidence of COVID-19, 11% of this group did actually report having had COVID-19 themselves, and 49% reported someone in their immediate social network, such as a family member, a friend, or a member of their religious congregation, also having had COVID-19. So at least, this is a survey. It has all the characteristics of survey data, and we are based on, our information is based on what people reported. But essentially, 11% reported that they had COVID-19 themselves. 49% reported that somebody in their immediate social network had COVID-19 too. Now, what do we know about the incidence of depression in the sample? As I explained earlier, the CESD score is a sum of 19 questions, and it goes from 0 to 3. So the possible range for that variable is 0 to 57. In our data, we have a mean CESD score of 21 with a median of 20. And in most studies of the psychologists and doctors who basically use the CESD in clinical settings suggest that a score greater than or equal to 16 points is considered clinically depressed. So based on this definition, 62% of the sample, is depressed, and that's quite high, I think. But it's probably a reflection of the fact that they were in the lockdown environment, possibly. So what we do is to statistically regress the CESD score on past religiosity. We include a binary variable representing whether a county had high or low strictness in lockdown periods, and then look at their interactions with religiosity. For those, some some people here who may be less familiar with the United States, in 2020, there were 3,143 counties and county equivalents, because Alaska and Louisiana call them parishes and boroughs, as I discovered, rather than counties in the 50 states and the District of Columbia. And we classified the counties as low or high strictness. So this is commonly used depending upon the number of days over a given period. And we look at two periods: the first lockdown, February to August 2020, and then the whole period in the US, February 2020 to January 2021, when the time spent outside the home was below a threshold level of either 15 or 20%. We're also including socioeconomic controls and state level fixed effects. Now, essentially in this table, the four columns are using four different definitions of strictness that are measured either with a 15% or a 20% threshold of time spent outside the home, and using these two time periods that I mentioned. Now, I'm not going to bore you with a whole lot of numbers, so let me just explain what this table is actually showing. Essentially, what we're finding with this preliminary correlational investigation is that religious people in general have a lower CESD score than non-religious people, depending on the specification. And you can basically see that there in the top line. If respondents or the immediate social network had COVID-19, respondents in this case are going to have a higher CESD score. Now, the interaction terms here are basically representing the difference in the effect of religion in the high strictness compared to the low strictness counties. So what does that mean? It means that if you get a positive value, that is indicating that the mental health of religious individuals in the high strictness counties was actually worse. But what we are actually seeing here, even in these very basic preliminary results, is that that is actually negating the religious advantage that people might have had. So the magnitude is such that it is almost canceling the coefficient on religion. So throughout this lecture, I've been arguing essentially that religious people have this positive effect in dealing with depression, and the correlational and causal evidence is suggesting that. But this very, very preliminary kind of investigation is suggesting that in the high strictness counties, any religious advantage that people may have had in mental health might actually be negated in the lockdown situation. And then, so then the interesting question becomes, why is that the case? Why is that religion advantage, which I and others have been arguing for years is actually quite important for depression, being negated in this kind of context? So what we're also seeing in our data is that in the low strictness counties, religious people at mean levels of religiosity were lower on the CESD scale. That means that they had better mental health by almost 2 points compared to the non-religious people. And again, that this difference is entirely absent in the high strictness counties, with religious people having statistically similar levels of mental health as the non-religious people. So what we are now doing essentially is, clearly the results that I presented, we're talking about the low and high strictness counties. The low and high strictness counties all over the US are not necessarily strictly comparable, because they could differ on other characteristics, including mental health. So what we're doing now at the moment is this: we're trying to identify state borders where the county on one side is high strictness and the other is low strictness, and then constrain our observations only to those counties and run the regression analysis again. So we're essentially right now only focusing, all the white areas are not border counties, all the pink ones here are the border counties. And we're checking for counties on the borders of states that are likely to have similar levels of mental health historically. So one of the things that we're also compiling at the moment, which I'm not showing you, but which we are currently still compiling, is mentally unhealthy days to get a measure of past mental health. And we're doing this with some data which Oxford University is assembling at this time. So what we're doing now is to restrict the sample only to those in the border counties, perform the same regression across counties that are more comparable, in order to be able to claim that the effect is well identified and not just correlational. Now, this is basically the group that we need to look at. These are the sample of respondents who reside in the border counties. Now, if you look very carefully, you'll see that most of these respondents who reside in the border counties, these little red dots, are in the pink regions. But you will also see, if you look carefully, that some of them are actually in the white regions. Now, these are all people who, by their postcode and their address, are residents of border counties, but at the time of taking their survey, some of them were clearly not observing the lockdown restrictions, or for some reason were very far away from, where we kind of thought they're supposed to be. So I guess this is one of the advantages of using the online survey as opposed to the in-person survey. But it is something that we will need to think about how to handle. The other thing we're looking at are the mechanisms through which the effect of religion might operate. One possibility is that if people didn't have access to physical services during lockdown, this affected their mental health. So we had questions in the survey about whether the respondent had accessed virtual services, because this might give us a clue about which aspect of religion mattered most for mental health and which therefore perhaps was the most, and by affecting that, did that affect their mental health more? So we have questions in the survey, for example, this one: what form did your religious interactions take under COVID-19? Tick all that apply. So we asked them to say tick if it applied: virtual religious service, drive-through prayer, online discussion group, virtual choir singing, online religious classes, other forms of religious interaction. And again, a preliminary look at the data. Hopefully when we're able to present this, when we have final results, I'll be able to show you this. But just to give you an idea of what we're seeing even now in the data is that 60% of the respondents reported having accessed one or more forms of these non-contact religious services during the lockdown periods. So this is actually, again, I think quite a high percentage, which suggests that these virtual services were being used quite actively. So going forward, we have many questions that we have to answer. In this project, we have to consider, of course, more broadly, the relationship between religion and mental health, as the handbook chapter is suggesting. We would like to look at, before lockdowns, was COVID-19 essentially spread by these religious gatherings? To what degree can you actually get at that or not? Was religion actually important for this? Now, with several countries, places of worship have reopened, and of course, face-to-face communication for religion is becoming important again. Is it going to be important even with social distancing? Now that we've had, this experience of virtual services, how are these two going to interface with each other? We're also interested, as I mentioned, in whether during lockdowns, COVID-19 restrictions on religion have in fact affected mental health or not. And at the moment, we're thinking about, how best to identify these, preliminary correlations and results that we're seeing. But, broader questions that I really think we should be thinking about are, what are the well-being aspects of these new forms of religious gatherings? For scholars of the economics of religion, do they actually have the same health benefits as physically going to a place of worship? I do feel that, some of these issues are something we should be considering more. And in the end, once, our project and other scholars around the world have actually done research in this particular field, if we find that religion really does matter for depression and anxiety and mental health and war traumas and all of these various areas, can we then think about it both in the context of the developed world, but also perhaps in the context of the developing world as one possible non-clinical way to complement current mental health policies? We know, for example, that there's many clinical ways to treat depression, but can we possibly think of religion as a possible non-clinical way to deal with mental health issues? So my sincere feeling is that going forward, there is a great deal of research that can be done and perhaps should be done on looking at the interactions between religion and mental health in many contexts, both developed and developing. So thank you very much for listening. I'll stop here and very happy to answer any questions, and be lovely to hear your thoughts on these matters too. Thank you.
Thank you, Sriya, for this very inspiring talk. I will now open the floor for the discussion, and I see one hand by Professor Zimmermann right now.
Would you like me to stop sharing my screen so I can see everyone?
This is up to you, and probably depends on the question also.
Okay.
Okay, my question doesn't really need the presentations, but of course it's related to it. I have two issues basically which came up, which one is more basic and one is more specific. Well, we know that the US is very religious in general, yes, in comparison, let's say, to Europe. The question is, why is this so? Because, well, the Americans are more or less migrants, yes, from large parts of other worlds, including Europe. Why are they so religious relatively? And to what extent would this mean? What does this mean for research? Well, what you find out, how much representative is this then for the world? It cannot be for the developing world, as you already indicated, and it cannot be for Europe. So it might be very, very specific. Also, what we realize is that the US has also lots of problems with COVID, yes, and but they have also lots of problems with drugs and mental health in general. So, I mean, in comparison, this is the same. Now, that's one issue. The other issue is a more basic question. There's a famous Latin saying, mens sana in corpore sano, a healthy mind in a healthy body. Yes. To what extent is religion, being a non-religion person, I have to say this, to what extent is religion different as a concept to analyze real life issues to sports activities? Yes, I mean, also can be physical, can be mental, can be, I mean, communicating and so on. So as an approach for research, what makes religion research, religion economics so different from these other activities?
Thank you so much, Professor Zimmermann, for those two very excellent questions. I'm sure there are many others here who are better qualified to answer them than I am, but I will give it a go. So the first question that you raise, that, you know, why is the US so religious compared to others? So I think one of the explanations definitely is, you know, one that you suggested yourself, that it is a country of immigrants. They came from, in many cases, very, very religious societies, brought with them in difficult circumstances, you know, their faith from you know, very different backgrounds. And that could be something that you cling on to because it's something that your parents taught you. It's something that you have the church community that facilitated and enabled integration and assimilation into you know, a new world and so forth. That could be one reason why the US is very religious. I think the other thing to think about in that context also is that, unlike in other parts of the world, so for example, India is a good contrast here, you actually see a lot of denominational switching in the case of the US. So if we're thinking about it as economists, and you're thinking about a religious market, and you're thinking about, you know, moving across religious denominations, there's a lot of switching between Protestant denominations and others that continually occurs in the US. Now, this is something that doesn't occur in the Indian context. You have instances, for example, of religious conversion, but they are on a far smaller scale than, for example, when you're looking at the United States. So my sense is that because there's a lot of denominational switching within Christianity, definitely, that is happening within the Protestant faith, definitely in the US, what you're also seeing is religious organizations essentially competing to offer services and other things that makes them attractive to devotees who potentially could join them. Now I just want to say that with the caveat that if there is anybody here who's not an economist and extremely religious, you know, thinking about religion in these terms might seem blasphemous to do that. So please forgive us for actually thinking about, you know, using this economics terminology to think about religious markets and switching and so forth. But if we are putting that kind of lens on it, my feeling is that, you know, the fact that the US religious market is much more competitive in that sense than perhaps, you know, this what you're seeing in some other countries might be one reason why the US is so religious. The other reason why I think in Europe you might find religion is less important is, I think, also in some cases, so if you look at the case of England, so the country that I live in now, The welfare state, I think, plays a very important role as well in influencing the importance of religion. So in this country, religious organizations were very important in providing various educational health services and so forth. Once you saw the development of the welfare state in the UK, you actually see a decline in the influence of religion. Now religion is becoming important again because we're having a lot of migration. But actually, my feeling is that when you have services that are being provided by the state rather than by religious organizations, that diminishes the influence of the religious organizations. This is why in developing countries where religion is very predominant, whether we're looking at Latin America and the Pentecostals, or Africa, or you're looking at India, these are all parts of the world where I think there is a lot of religion is very strong, and services are being provided by religious organizations, as I have myself documented in my research. So my sense is that that makes these areas very religious and different in some ways to Europe, and different to the United States as well. So for your first question, I would say that's why I think the US is actually very different. Now, I think the big issue which most economists of religion have always pondered about is, with economic growth and with wealth, why is it that you didn't see secularization and a diminishing importance of religion? And I think that is where there is a lot of research to be done to understand why, what are the benefits that religion perhaps has, not just for the poor, but also for the rich. Is it the network aspect? Is it that they're getting help with childcare and information on schools and information on jobs and other kinds of social networks? That might be something that might be relevant here. And that brings me to your second question, when you were mentioning that the healthy mind is connected to the healthy body. I think, and why is it that sports and athletics and other activities which could also bring in social community related aspects, what is it about religion that's different? My sense is that in our we've not done that yet for the COVID religion project. But in the paper that we did on religion and depression amongst adolescents, we actually looked at that, whether adolescents, the students' membership of athletics and sports and others, did it give them the same benefits to reducing depression as membership of the religious school choirs and so forth. And what we found is that even after they were members of sports clubs and so forth, the religion effect was not going away. And so then, although in that paper we didn't explore in more detail what was it about religion that was different to being a member of an athletic club or a sports club, clearly there is something there that was of value to the children in that particular study. But I agree with you that if it's only about social interactions, then there's no reason why sports and other kinds of communities activities that people engage in should not be giving you the same positive effect on reducing depression. I think one thing to think about, though, and perhaps I don't know if this is so relevant to the US, but it's certainly relevant, I think, if you're thinking about non-Christian religions. So religions like Hinduism, for example, the religion is not just about faith, it's actually about a way of life. And so it prescribes diet, it prescribes a way of living. It doesn't necessarily say you have to attend temples. It doesn't have a religious book as such, but nevertheless, it is actually suggesting ways in which people live their lives. So in that sense, the physical health and the mental health are indeed being commented upon by the religion and by the religious tradition, whether or not people are actually observing that or not. My own feeling in general, though, is that with a lot of work on religion and health, the great focus has been on religion and physical health. Even in countries like India and other places, but different parts of the world, the context has always been looking at religion in the context of poverty alleviation, looking at it in the context of physical health. We've not actually, I think, spent a lot of time looking at religion in the context of mental health. So the country that I know best is India. We've only had a mental health legislation in India 4 years ago in 2017. Now, given that India has been independent, as an independent nation for 70 odd years, the fact that a formal mental health legislation, which has nothing to do with religion, has only been enacted 4 years ago, suggests that mental health is now finally on a policy agenda and on the policy map. But I think that's one of the reasons why, in the context of religion research, we've actually been focusing much more on physical health than we have on mental health. But I agree with you completely that I actually think the physical health and the mental health are tied in together very closely.
Thank you very much.
Thanks.
Excellent. Okay.
We have 2 more questions and 2 more minutes to go. So we will see how we manage. One question is asked in the chat by Eric Kovac. Excellent point about the welfare state. Exactly what I wish to ask is the relative importance of religion as such versus the presence of the peer support network aspect. And I will also give a floor to Pavel Yernov to ask his question, and then you could respond to both of them together.
Hello, thank you very much for the very interesting talk. I have a question on the first topic that you discussed, which is also the first bullet on your last slide, which is the role of religious gathering in spread of COVID-19. And in particular, what I'm interested in is to which extent it's more difficult to restrict religious gathering than other types of gathering. So I can tell you from my country, Israel, it was extremely difficult to restrict religious gathering. It was much easier to shoot the economy down and, to kill huge proportion of GDP than to restrict religious gathering. And the question is, can we assess empirically the role of actually opposition to restriction of religious gathering in the spread of the virus? Thank you.
Thank you very much for both of those questions. If I may, I'll start with Pavel's question. I quite agree with you completely that I think because COVID came upon everybody very suddenly, and we know from Janet's work and others that people were immediately appealing to religion as a way of dealing with the fright and the scare that they felt as soon as COVID kind of came upon the world. That it is very difficult to restrict gatherings in those kinds of circumstances. So we will have to look into this issue, whether there is any evidence available to show whether gatherings were in fact restricted or not. How one would actually do that, one would have to look at, even study accounts of particular religious gatherings, which we know happened in different parts of the world, because we have a lot of media reports that actually talked about them in different parts of the world. We're collating that at the moment. Whether we're actually going to be able to say there was, formal evidence that the gatherings were restricted, that may be more difficult to show. But I do agree with the more general point that I think it would be very difficult in that kind of situation to restrict a religious gathering if it is spontaneous and if it is a means which people are using to cope with the well-being consequences of being in a pandemic situation. My sense is that I think as time moved on during the lockdown, and lockdown restrictions were really being imposed in terms of announcements that were actually being made in different parts of the world, and churches and temples and mosques and so forth were being closed, it was very clear that one couldn't physically go to the place of worship. So we could empirically actually try to get at how long a place of worship was actually physically closed to its followers. So in the US work that we're doing, we were trying to get at virtual services, but that does give us an indication of when they were not actually going and attending the physical place of worship. I do agree with you that empirically this is going to be difficult for us to get at, but my feeling is that, as economists, we rise to challenges. We will try our best and try to see to what extent we can actually at least get some information on gatherings in different parts of the world and how different religions and denominations perhaps reacted to the situation in which they found themselves. From Eric, so Eric, your point about talking about the relative importance of religion compared to the peer support network, I think it's absolutely the case that the welfare state is going to be important. To what extent you actually use the services, though, may depend a lot on to what extent your peers are also using the services. So if for example a local temple is providing education and healthcare and computer computer classes and English language education classes and so forth in a developing country. If your peers are using those classes, then it's very likely that you're going to, you might use them too. So my sense is that the welfare state argument and the peer effects argument might actually be complementary rather than substitutes, may actually be working together to make sure that the services that religious organizations are providing, are actually being used as well.
Thanks a lot. Unfortunately, we don't have much time for any further questions, but the topic is indeed very inspiring and important. So I suggest everyone who still left with the question, please get in touch with Professor Iyer directly and discuss this also per email. And with this, I would like to close this session. Thank you again, Sia, for this wonderful talk, and thank you, audience, for the wonderful questions. We will see each other at some other event, and also please follow the handbook project and the chapters on religion in particular. Thank you again, and see you next time. Bye.
Thank you very much.